smokers get lung cancer. Some smokers don't get lung cancer. Non-smokers get lung cancer. Non-smokers don't get lung cancer. So there's a 2x2 of smoke, don't smoke, lung cancer, don't get lung cancer. Every one of those squares is populated, but not equally. So that means that smoking is neither necessary nor sufficient for lung cancer. We know that, and nobody would argue that smoking increases the risk of lung cancer. For some reason, when it comes to lipids, people don't seem to see that not only is there an overlap there, it's even more profound. LDL is not just associated with it. LDL is a necessary thing. You have to have a lipoprotein take cholesterol into the artery wall. It's just that that's not sufficient. So on the one hand, you ask a great question. I'm glad you used the term residual risk because that's a great rigorous way to describe it. I'll explain to the listener what you meant by that. But residual risk means why is it that some people, when they have low LDL, you've already pharmacologically lowered their LDL, they still can go on to develop atherosclerosis. And there's two arguments here. One argument is because we never fully eradicate LDL. So there's always some amount of lipoprotein that's sitting around. The other is the other risk factors still matter. Arguably, one of the most important risk factors in residual risk is Lp(a). Most doctors don't even know what it is, let alone measure it. So you have lots, and if 8 to 12% of the population, which I think is a conservative estimate, by the way, Sam Tamikis might say it's closer to 20% of the population, has elevated Lp(a), and we're only looking at LDL cholesterol, which is the thing that most people are looking at, and you say, well, this person's LDL cholesterol is 70 milligrams per deciliter, they're at the 10th, 5th percentile, there should be no risk. But if they have an elevated Lp(a) and you're not measuring it, there's residual risk, and that could be 1 in 5 to 1 in 10 patients. But where I also would push, and I think you would agree, and I think Dave Feldman would agree, is what about hyperinsulinemia? What about elevated uric acid levels? I mean, there's so many other metabolic factors that are driving it. And remember, you don't need 200 milligrams per deciliter of LDL cholesterol. That just makes it much more likely that those sterols are going to be bombarding the artery wall and that getting retained within the endothelium and all those other things. So to me, that's sort of why the problem statement that you gave can easily coexist. Let's ask the other questions. I didn't answer the other one. Why is it that somebody can walk around with an LDL? I have a woman who's 55. LDL cholesterol is easily 180 milligrams per deciliter. Concordant with her LDL particle number, she's probably about 2,000 nanomole per liter. Her HDL cholesterol is pretty high. Her triglycerides are pretty low. She almost looks like she has familial hypercholesterolemia, but she doesn't. She's in her mid-50s, and her risks are high enough. I sort of had this discussion with her, which is, look, we pulled as hard as we possibly can on the nutritional levers and all the other levers. There's a pharmacologic consideration here, which is, do we want to put you on a statin? She's a fine candidate for a statin. She has a high degree of cholesterol synthesis. She also absorbs quite a bit of cholesterol, so she would do great on ezetimibe. And she was a little bit hesitant. So I said, look, let's get a calcium score and a CTA on you. And sure enough, both came back perfectly clean. So her CAC is 0. Her CTA doesn't show one speck of soft plaque. Neither of those are a guarantee of anything, but they make me feel a heck of a lot better. And so the discussion with her is, well, okay, I feel more comfortable if your decision is you don't want to be treated. But I said, be sure that the clean CTA and CAC are really giving us a 5 to 10 year window. So we should at least reserve the right to revisit this.
Well, that's also an interesting thing. So the LDL as monotonic area under the curve over the course of a lifetime, I have more questions than answers on this. So like, for example, and maybe turn the tables and interview you for a minute.
I feel like we've already done more.
Yeah. But does the LDL particle get oxidized in the plasma or in the endothelium or extracellular matrix of the intima?
I think it's getting retained inside the subendothelial space. It's getting locked up there by proteoglycans. I think that's where the mainstay of oxidation is happening. Maybe phrased another way, I think that's where the oxidation is most harmful. Because remember, and I was actually talking about this with a patient today, atherosclerosis is primarily an inflammatory disease. The destruction is inflammation. The lipid is just the trigger. If something else, if UV light triggered an inflammatory response inside of artery walls, none of us would be outside. So the issue is, as that sterol is getting oxidized in a place that we do not want inflammatory cells, then I think we would be a long step of the way, which really comes back to your point about this patient. It's quite likely that this patient of mine with her LDL of 180 milligrams per deciliter is going to sail through life and not get atherosclerosis, at least for the next 40 years. Will that tell me that LDL doesn't play a causal role? No, it will just tell me that there are other variables. Maybe her particles just don't get retained very well. Or maybe when they do, they just don't get oxidized.
Which I think these are actually critical and important things to reflect on. So lipidology should be a branch of hepatology in a way, because the liver is synthesizing most of those particles and also responsible
clearing them
for recycling and clearing them.
That's an interesting idea. I like that idea.
Yeah, because it's really, and I think of it because it's like, how do we unify this? So was there a phenotype pre-1950 not related to smoking that had advanced heart? So we have a few different pathways to kind of early CAD. So it's going to be smoking, number one. So if you're doing a family history and their father was a smoker, you can kind of almost discount it.
Hypertension?
Yeah, smoking, hypertension, the familial hypercholesterolemia, and then the new phenotype would be metabolic disease. I would call it hyperinsulinemia and liver dysfunction. So I was thinking about the familial hypercholesterolemia the other day, and I have an interesting thought, which is that the commonality is not that the LDL particle count in the blood is higher. It's that the residence time of those LDL particles is higher, independent of the number of particles. And the reason for that is most familial hypercholesterolemia is due to one of two defects. One is the receptor is broken, and B, there's some part of the ApoB that doesn't match the receptor ligand. There's a receptor ligand mismatch. Right?
Yeah, I mean, to be clear, there are probably 2,000 different mutations that produce that. But yeah, it's an LDL clearance problem, which it's interesting how you describe it. I guess I think of it slightly differently, which is not incompatible with what you've said. Familial hypercholesterolemia, FH, means you don't clear LDL well. It's a very heterogeneous disease that, again, my last counting was over 2,000 different genetic pathways could get you there. And the phenotype is high LDL cholesterol, high total cholesterol, often high HDL cholesterol as well. And I sort of think of it as either that you don't have enough receptors or your receptors don't match your particles, which I think you've described in a slightly more granular way.
Yeah. And so that to me, so an LDL of 180 in somebody with some mild FH variant and an LDL of 180 in somebody who's metabolically healthy with no family history of heart disease, can we look at those as two distinct entities? And do we apply the same population studies to both of those people, right?
I think that's a great question. I think that's what Dave Feldman and folks like that want to understand. And I'm not that close to this discussion, so I don't know if they've ever been able to get a hold of data from Mesa or Framingham that would enable that. It would be hard, though, to know that. So it might be something that you have to study prospectively, which will be very challenging.
I think actually Dave Feldman did a little analysis on the NHANES data, looking at the centenarians. And so he put them into tertiles or quartiles and found that the people with the highest LDL lived the longest. I mean, I'd have to look more closely at the data on that. But I think if you look at adding the metabolic syndrome into that, if you look at people with hypertriglyceridemia, the LDL particle residence time is 5 days as opposed to 2. And so that, I think alone, like the arteries are an oxidative environment. And so if you can make some calculation of, so they did this with like, they labeled leucine or valine or one of the amino acids went for cholesterol production. And so if the residence time goes up, your oxidative potential goes up. So is it a pre-oxidated? And then secondly is I'm always trying to relate things back to, with my kind of biased assumption that the American food supply is poisoned. It's like, did this exist 100 years ago? And if not, why would it not have, or why would it have? So I think Tom Dayspring, you had talked about, he's really bearish on the phytosterols.
He's bearish on the use of phytosterols to lower cholesterol, which they do lower
because
cholesterol.
There's a number of things that lower cholesterol, right?
Right. So phytosterols do because they outcompete cholesterol at this Niemann-Pick C1-like-1 transporter. The problem is phytosterols, in the context of people who have defective ATP binding cassette transporters, are more oxidative. They're more. So in other words, you can lower a person's cholesterol and increase the risk of atherosclerosis.
Yes. And I think that happens the same in the saturated fat, polyunsaturated fat debate. So if you look at, would you agree that the kind of dietary paradigm around saturated fat was largely kind of just a misdirection in nutrition science? Or
meaning, do I think that the phobia of saturated fat was misguided?
Yeah.
Yes. But again, I take a view, which is, I saw a patient today. It's funny, we were looking at his labs and I was like, oh my God, you've been my patient for exactly 1 year. You know, we were like a day away from his 1 year anniversary. And so we're looking at his labs dated a year ago tomorrow. And you want to know what his LDL cholesterol was on the day that he came to me? It was like almost 400 milligrams per deciliter. His LDL cholesterol. Yeah. And he was mainlining, he was on a very low carbohydrate diet, mainlining saturated fat.
Mm-hmm.
I mean,
yeah, I've seen the same.
So is that healthy? I'm going to have a hard time saying yes to that.
I think there's a couple of considerations there. So one is, I see it a lot when people do a low carb diet without also having a high fiber diet. So fiber basically feeds your gut microbiota. They make short chain fatty acids. They also metabolize cholesterol and alter it so that it gets excreted in the stool rather than reabsorbed. Right? I think that I have a very weak understanding, but that's my understanding there.
I actually don't know enough about this.
But saturated fat is kind of inert. Most animals store their fat as saturated fat. They don't store it as polyunsaturated fat because polyunsaturated fat is highly chemically reactive. We use it for cellular signaling, and we kind of only consumed it in micronutrient quantities. I think it was until about 1910 when we had the industrial seed oil revolution. Polyunsaturated fat intake was less than 0.5% of calories.
That can't be right.
Yes.
How is that possible? But there's polyunsaturated fat within meat.
Trace amounts.
No. If you look at, like, if you take a piece of steak, it might be directionally, it might be a third saturated, a third monounsaturated, a third polyunsaturated, isn't it not?
We'll have to do a little bit of research afterwards, but I think the total intake, I'm quite certain it was less than 1% of total calories. So
maybe the total intake of oils that are predominantly polyunsaturated was that low, but I don't think the total intake of polyunsaturated fat could have ever been that low.
I think it is, and then it's gone up to 8 to 10%, so a 20-fold increase. I think there's some key differences between...
Wait, we must eat more than 10% of our fat today is polyunsaturated, though.
10% of daily calories.
Oh, okay, the 10% of fat calories, okay.
It makes sense. I mean, 60% of American calories come from 3 crops, like corn, wheat, and soy. But I think in terms of talking about medical theories, I think the polyunsaturated fat thing is going to be the next kind of identified demon that we find. We already knocked out trans fat, but polyunsaturated fats in macronutrient quantities, I think, have the potential to be very toxic because they're easily oxidized. The industrial process that we use to kind of refine them strips out the natural antioxidants. You don't have the vitamin E, you don't have kind of any of these natural stabilizing compounds, and they create peroxyl radicals very easily. So if we're talking about per particle atherogenicity,